Thank you very much. Hello and welcome to Medicines from Around the World. Today we're going to talk about cyclosporin and the miracle of transplantation. And we have two guests. Our first guest is Dr. Paul Keown, who's from the BC Transplant Society here in Vancouver, British Columbia. And our second guest is Dr. Andy Chalmers, who's from the Department of Medicine of the University of British Columbia. Now we're going to talk about cyclosporin, and I think without a doubt cyclosporin has been the greatest drug discovery of the last 25 years. It was actually discovered in Norway in a soil sample very similar to this one. And what we're going to do is find out today how it was discovered, how important it has been to the miracle of transplantation. But more so, we're going to talk about some of the newer uses, the possible uses of cyclosporin in the treatment of a whole series of diseases called autoimmune disease, diseases like arthritis, diabetes, and so on. So first of all, let's talk about how it was discovered. And for that, we have Dr. Keown. Paul Keown was trained in medicine in Manchester in England. He then did 9 years of fellowships in Manchester, Paris, and London, and then came here eventually to be the executive director of the BC Transplant Society. Dr. Keown is also a research scientist, a professor in the Department of Medicine at the University of British Columbia. So Dr. Keown, how was cyclosporin really discovered?
Well, thank you very much, Dr. Cass. Like almost all of the other major discoveries in medicine, it was purely by chance. Nobody had any reason to suspect that cyclosporin would exist in the form that we now know it or be produced in that way. And many years ago, a biologist who was touring through northern Norway brought the soil sample, the kind of sample you've just seen, back to the pharmaceutical company in Switzerland where it was processed, hopefully to produce a new antibiotic. And I think we even have a slide of the place cyclosporin came from. It was a very high, treeless, windy plateau in northern Norway, really the land of the midnight sun. And it's the location of all the stories of trolls and dwarfs that come in Norwegian literature. And once cyclosporin was produced and developed, it was found to have a very powerful effect on the immune defense responses of the body. It works in an unusual way, and it works very specifically by blocking some of the actions which cause grafts to be rejected, but it allows many of the other defense mechanisms which we have to operate normally. It works very particularly at the level of the DNA code. That's the code where the messages for almost everything we do and the way we fight disease, the way we reject a graft, are encoded. And at that point, it very selectively switches off the actions of the DNA which would lead to rejection of the graft. The body recognizes the foreign antigen, sees that it should not be there, does its best to eliminate it, and produces various cells and hormones which get rid of the graft. The cells are the white cells of the body, the cells that fight infection, almost exactly the same cells that fight the graft to destroy. They invade the graft tissue. There they produce a whole series, a cascade of hormones that cause inflammation, cause the blood vessels to be destroyed, and finally the graft is itself destroyed. Cyclosporin works very selectively to prevent this. It is the first agent that we have ever come across in medicine that allows us to block the mechanisms for graft rejection while leaving us able to fight all of the other diseases that afflict us on a day-to-day basis. We'll see if another one of the slides is working at the present time. But with the development of cyclosporin, all of us in medicine began to be able to see for the first time that there was a hope that we would be able to do something that had been our dream for thousands of years, to place foreign tissue into a patient with the real expectation that this graft would survive and would not be destroyed. On this slide you see the fungus, which has a very long Latin name, Polycladium inflatum, for those of you who are science buffs in the audience. This we now know exists in many other areas quite apart from the area it was found in northern Norway. And it grows particularly in damp, cool areas in and around forests. When we begin to look at the rejection response in greater detail, and these are understandings that we've gleaned in the last 10 years from the biology of medicine, we can see that certain cells in the graft, particularly the heart graft, as you see in this case, are recognized by the body as foreign. And this message is carried back to the lymph glands, which lie around the organ, where this message is processed. The cells which are to attack the graft are activated, they flood into the bloodstream, they are carried by the blood back to the graft, they infiltrate the graft tissue and destroy it. And we have to act selectively at one point in that arc to block that response. The picture you now see shows what we call an electron microscopic study of the cells which are actually involved. The top cell shows you the fingers, the filaments of the attacking white cell binding on to its target within the graft, liberating the hormones which cause the destruction, and punching a great hole in the target cell, through which the cell will literally bleed to death. That's the process that we have to stop. This chromosome, which encodes all of the information, not only for graft rejection, but for everything else we do. And once the graft is placed inside it, this chromosome begins to unfold so that its message can be read. It's like a string of beads which is very tightly coiled, and as it uncoils, the information is expressed and then can be read from the chromosome. Cyclosporin works specifically to prevent this uncoiling of the DNA message so that the attack signal is never produced and the graft is spared. Now, how do we come to use it in clinical medicine? Well, we'll start with the simple way. Everybody knows about kidney transplantation. We do hundreds of kidney transplants a year in British Columbia now. In fact, British Columbia has come to be one of the highest transplanting areas of Canada. But until transplantation was generally available, people with kidney failure had to exist on dialysis, which is not a pleasant form of existence. Yes, it keeps us alive, but it doesn't keep us in perfect health. We are very anemic, our hemoglobins are low. In general, we tend to be sick. And we're maintained 3 times a week or 4 times a week by attachment to a machine which helps to purify the blood, a sort of biological washing machine, if you like. With transplantation, this is changed entirely. We put the new kidney in place, the new kidney takes over where the old kidney failed, produces all of the hormones that the old kidney used to produce, purifies the blood, and returns us to normal health. Now, with the medications that we had to use until cyclosporin came along, this was a very dangerous procedure, and people spent 4 or 6 weeks in hospital. Now people go home very quickly, and this picture you see shows a lady returning for Christmas dinner, discharged from hospital on the 5th day after her kidney transplant. So not only is success now vastly better, we're looking at success in the range of 80 to 90%, but also the complications are reduced, the time in hospital is reduced, and very importantly, the costs that we all pay as society are reduced. Many of the causes of kidney failure we cannot prevent, but some of them we hope we will be able to prevent. And one of them that I'd like to talk to you about, and I think Dr. Chalmers may follow afterwards, is the question of diabetes. Diabetes, as you know, causes blood vessel disease, and over time can destroy the eyes, the kidneys, and many other vital organs. If we can prevent or reverse the complications of diabetes, we can also prevent the kidney disease that comes with it. And we're getting closer and closer to this possibility. At the moment, we're at the phase of being able to transplant the pancreas, which is the gland which produces the insulin, which is lacking in diabetes. And we can now transplant both the pancreas gland and the kidney at the same time in somebody who has diabetes. And as you can see from the picture on the slide, both of the organs go into the tummy on opposite sides, and usually both begin to work at the same time. So in the one operation, both the kidney failure and the diabetes may be cured. But we hope that very soon we'll have a very much simpler operation under the cover of cyclosporin, where we will be able to take the cells from the pancreas gland, which themselves actually produce the insulin, and inject them in the form you see them there into the body so that they will not be rejected, so that we can cure diabetes at its very early stage. And an even later development, and one which is yet another step of which has yet another step of interest, is that we can coat these cells with a special substance so that they will not be attacked by the body, and then we can begin to withdraw the cyclosporin from them. Now, over time, the operations that we've been involved with have got more and more complex, and as you can see, more and more difficult. But the benefits when we're able to achieve them are good. First of all, we have operations like liver transplantation. The liver is destroyed for many reasons, of which alcohol is only one. When the liver is destroyed, there is no treatment such as dialysis to maintain the person in health. You die if you lose your liver. So with liver transplantation, we're able to take out the sick liver and replace it with a healthy liver in its place. And then we sew together the blood vessels and the drainage tubes from the liver, and the liver begins to work. This is a big undertaking. And the other similar size undertaking is the operation of heart or heart-lung transplantation, when people lose the heart or lung function. And this, I think, is one of the most dramatic slides that I possess, which shows a chest cavity completely empty with both heart and lungs removed as we begin to replace the heart and lungs for the patient. Now, these are technically very demanding, but nonetheless, the success rate is quick. And from some of the pictures I'll show you, you see that people do return to a really normal life. The young gentleman who's shown in the slide at the present time has had a heart replacement and now is playing professional soccer for a team in the United States. The next is equally interesting and exciting. Is a young man from London, Ontario, who had a heart transplant and then returned to being a professional jockey. Now rides weekly and is doing very well. We haven't bet on him yet. And then our second heart transplant in British Columbia, who was a marathon runner before he developed heart disease, is now back teaching full-time and in fact running marathons again. For all of this, we need several things. We need the surgical skills. We need the drugs such as cyclosporin, which help to prevent rejection. But most of all, perhaps, we need the organs to make it possible. With the organs available to us, we can cure most of the organ failure which exists in British Columbia and throughout the world at the moment. The future is very exciting. Cyclosporin is one, perhaps the flagship, of a whole new family of immunosuppressive drugs, vitally important for transplantation, and as you'll hear in a moment, also for other serious crippling diseases in which the body begins to attack itself. And alongside cyclosporin are a whole range of other new different immunosuppressive drugs which will carry us from this to the next century, and I think make transplantation something which is done commonly, easily, simply, and effectively. I'll hand back to Dr. Katz at that time.
Thank you very much, Paul. It certainly is exciting, and there have been a lot of advances. But I guess with every drug, there's always benefit versus risk. You talked about the benefits. What about the risks? Are there a lot of side effects associated with how cyclosporin is used?
There are some side effects, there's no question. It causes a little bit of hair growth. It may cause some toxicity to the kidney if the dose is too high. It may cause mild tremors. But all of those in general can be contained. The benefit in this particular drug far outweighs the risks that we have, and so it's become the major drug that we use in this kind of medicine now.
Now, I'm sure there are some questions. There must be questions from the audience. People that know people who've taken cyclosporin, want to know a bit more about them. Sir.
I have two questions, if I may. First of all, whatever prompted people to go poking around in soil samples looking for antibiotics? And the second question is there a point at which the transplanted organ ceases to be a foreign organ, or is cyclosporin a lifelong requirement?
Well, the first one is interesting. The second one is important. The first one is really the basis of a process by which most drugs are discovered. Biologists who work for these large multinational drug companies, when they tour to different parts of the world, traditionally bring back samples, and they look in these samples for fungi or other organisms which produce drugs which typically have antibiotic function. And about 20 years ago, cyclosporin was being examined for its antibiotic function and was then put on a shelf, and latterly was brought down to be re-examined just as part of a routine screening program. So it was pure serendipity that we found that it really had this effect. But the second one is very important. We hope to be able to achieve exactly what you described. It's called tolerance. That means that after a period of time, the body will begin to accept the transplanted tissue as its own. We're not at that point yet. We cannot produce that, and if people stop taking their medications, the body will resume with full force its rejection response and destroy the graft. But the time will come, we hope within the next decade or two, when we will be able to transplant a graft with true tolerance.
Right. Any more questions over here? Here's one. Right.
Why is it called cyclosporin? Why is it called cyclosporin?
Sporin, because it comes from a fungus. Cyclo, because the molecule is round. Very complex.
Like everything else, there's a simple answer, right? Now, the other thing, of course, is that at the moment we're giving it generally in the body. And that must have effects on other parts of the immune system. So if that's the case, then are there better ways to give the drug that'll perhaps allow some of the immune system to better help us while the cyclosporin is working?
Yes, indeed there are. In fact, we're beginning to look at local delivery of this and many other drugs. Because just as Dr. Katz says, there's no point in delivering the cyclosporin to parts of the body that don't need it and may actually suffer from it. So for eye disease, I think the future will be topical application. For skin disease, topical application. And even for organ transplantation, we're beginning now to look at the possibility of delivering the drug through special surgically implanted micro pumps to the organ that is at risk of rejection.
Thank you very much. Well, I think you've raised some points, and perhaps we'll go to Dr. Chalmers and then come back to some more questions. Andy Chalmers was born in Malawi in Africa, and he was educated in Cape Town, in University of Toronto, here at the University of British Columbia, and he probably is best known for the fact that he treats a lot of patients at the Arthritis Center here in Vancouver, and he's also a scientist in the Department of Medicine at the University of British Columbia. And Dr. Chalmers is very interested in the possibility that cyclosporin can be used in the treatment of rheumatoid arthritis and other possible conditions. So, Dr. Chalmers, why don't you tell us a little bit about that?
Okay, well, what I'm going to talk about really is cyclosporin in a group of diseases which are called autoimmune diseases. And they're a very peculiar form of disease. Perhaps I could borrow that. Peculiar form of disease in which the body, in fact, starts to attack itself. So the immune system gets turned against the organs of the body, and in various different diseases, it affects different organs. For most of these types of disorders, there are two factors that are required. A trigger, something outside the body that kind of sets the thing off, and then in addition, a genetic background or a tendency in the individual which allows them to get the disease. Once the trigger and the right person meet, the disease starts, the immune system is turned on, it really gets completely out of control, and it begins to attack organs by the process of inflammation. Now, it can cause inflammation directly in the organs. The organ that I'm most interested in, and it's hardly really an organ, is the joint. And in the joint, inflammation occurs, and in, for example, the disease rheumatoid arthritis, as that inflammation occurs, a large number of small molecules are released, and what they do, in essence, is to destroy the joint. And that's what produces the intense crippling in people with rheumatoid arthritis. So this is basically what the autoimmune diseases are. Most of the autoimmune diseases, we really don't know what the trigger is. In many of the more common autoimmune diseases, we're beginning to understand what the genetics or the backgrounds are. But I thought what I would use kind of as an illustration for you is an unusual disease, but something perhaps that you might be a little bit familiar with. And that is a disease or set of diseases in which there is a known trigger. In this particular disease, which is called polyarteritis nodosa, a very, very unusual disease, can be triggered, in fact, by the hepatitis virus. The hepatitis virus, in most people, causes hepatitis. I'm sure everyone's aware of that. But in people with specific backgrounds, a number of other things can occur. For example, in some people, the hepatitis virus appears not to attack anything. It just simply floats around in the body, and people become carriers for the virus. That's not a terrible state. In most people,
as I've said, you get an acute hepatitis. The body's defense mechanisms are satisfactory enough to clear the virus goes away, the disease is gone, and the person recovers. But there are three conditions on the slide, one called polyarteritis nodosa, one which has got a very, very long name, cryoglobulinemia, and then a form of chronic hepatitis, all of which are autoimmune diseases. In polyarteritis nodosa, what happens is that the inflammatory process that's set up by the virus, the trigger, in the immune system, sets the immune system attacking blood vessels. And what it does is to attack arteries. It attacks arteries that go to the lungs, to the skin, to the bowel, to the nerves, to the kidneys. And the result of this is that it can cause damage in each of these organs, and in fact, if not treated promptly and aggressively, result in death of the patient. The other two are also similarly autoimmune diseases where in chronic hepatitis, the whole system attacks the liver, but also can attack the joints and the blood vessels. And in cryoglobulinemia can affect the kidneys. The disorders which we don't know the cause of are somewhat more common. The one that I'm most interested in, as I've already mentioned, is rheumatoid arthritis. But psoriasis, which is a very, very common skin condition, is in fact another of these diseases where there's a genetic background that predisposes people to it, and the immune system in this particular situation is attacking the skin, although in certain circumstances it can also attack the joints. The other disorders that I've listed are much less common, diseases like myasthenia gravis, where the muscle function goes, systemic lupus, which is a very significant disease which can affect the kidneys, the lung, the brain, all sorts of organs. These are all examples of autoimmune diseases. Dr. Katz mentioned diabetes. There are also diseases of the bowel, group of disorders called inflammatory bowel disease, where the bowel is in fact the focus of the inflammation, and where people in fact get a lot of inflammation in the bowel, often bleeding from the bowel, inability to absorb from the bowel. And really, most of these disorders are particularly unpleasant. Now, of the ones that I've been most interested in, rheumatoid arthritis, I think people are mostly aware of. I don't think people really are aware of how common the disease is. It affects somewhere between 1% and 2% of Canadians, so it's a very common disease. Fortunately, in most people, it's a disease that we can control with treatments that interfere with inflammation, things like aspirin and its analogs. We sometimes have to use drugs like gold, which is, again, a gold compound, not gold itself, as an injection which can bring the disease under control. But in the problem in rheumatoid arthritis, the thing that really, I think, makes it a difficult disease to treat is that what we found is that the drugs that we use, the drugs that are effective, are only effective for a brief period of time. So, for example, when we start someone on gold, we can anticipate maybe 3 to 5 years of the drug being effective. After that, it loses its effect. And the same is true of all of the drugs that we have. We have a drug called penicillamine, which is another drug that came from a fungus, which is effective in the disease. Again, it even lasts for less time, maybe 2 years, and so on. With the result that we have this disease, which I hope people realize is actually a disease of young people, in fact, young women, which hits people in their youth, continues aggressively to destroy joints unless we can control it, and ends up leaving people very crippled if we don't. It doesn't kill people, although if you look at the slide, there are areas which which the disease can attack, which can be very serious, such as the lungs, the eyes in particular, where it can cause significant damage and inflammation, and where in fact people can go blind from the inflammatory process. Cyclosporin. The largest trial of cyclosporin in rheumatoid arthritis was in fact carried out in Canada and was published, the results of it were published about a year ago. It was carried out because of a belief that in people who have the very severe disease, the people who have other organs affected, the people who are not controlled by regular agents, there was a major concern that we were running out of things that would work. And the types of drugs that were available to us were the sorts of drugs that we tend to use in cancer. Now, those drugs do affect the immune system. The way they affect the immune system is to literally blast the whole of it and, in fact, destroy all of the defense mechanisms of the body, leaving the patient pretty well helpless to deal with infection and at very severe risk of developing those kinds of things. So that these are very nasty drugs, which in addition can affect the bone marrow, the blood-forming organs, and in fact wipe them out. And this was the appealing thing about cyclosporin, is that it appeared to affect the immune system in a very kind of scalpel-like way. So that instead of cutting the whole system out, what it would do is to turn it delicately off and enable the disease to come under control without imperiling the immune system. Now, clearly, I wouldn't be sitting here talking about this with you if it didn't work. In fact, we took 120 patients from all across Canada. We took some of the most severely ill people, people who had failed on every other treatment, people who one wouldn't expect to do well on any treatment. But in fact, what we found was that this particular drug, in the way we used it, which was in much lower doses, in fact, than are used in transplantation, was capable of controlling rheumatoid arthritis very effectively as any drug that we currently have. And the other thing that we found, which was very, very helpful and actually a wonderful thing, was that in fact the side effects in the patients were relatively minimal, relatively easy to control, and the patients did extraordinarily well. Now, there are some disadvantages, and Dr. Keown's talked about some of the disadvantages of cyclosporin and in the side effects, in the fact that it can affect the kidney, that it can affect other areas such as producing hair and a little bit of nausea, that it can produce high blood pressure. These things are by and large easy to control by altering the dosage of the drug or treating them. And in fact, by virtue of the quality of life that we've brought to these people with rheumatoid arthritis, they seem willing to accept these risks, which are certainly less than the risks of the other drugs we used to use, for the improvement in their disease and the control of their disease. There are a number of other autoimmune disorders in which we are trying to look at the effects of cyclosporin. Psoriasis is one where it's been shown to be effective, and there are a number of other diseases where we're beginning to look or have some evidence that the drug really works. I think there's a lot to be done in the future in terms of exploring its role in this group of autoimmune diseases, but certainly it's been a major advantage in treating these very severely disabled people with rheumatoid arthritis.
Thank you. Thank you very much. Are there any questions coming out of what Dr. Chalmers was saying? I think one of the, oh, here's one, right here. Could you stand up so we can see you?
Okay. I'm concerned about the cost. Will the citizen be bearing the cost of all this, or will it be a government subsidy that'll help patients?
Well, actually, I can give you some very good information on that. In fact, in the last several weeks, the provincial government has agreed that people who have severe rheumatoid arthritis who require the drug will in fact have it subsidized. So that the drug, which is expensive, will in fact be provided in this province. That's actually only true in BC at the moment. We have had a very good relationship with the government here, who feel that these people certainly require this type of treatment, and hopefully in other provinces in Canada over time it'll become available. But at the present in BC, certainly the patient will not have to bear the cost.
Good. Does that answer your question?
Yes, it does. Thank you.
I guess something emanating out of that, Dr. Chalmers, is where does it fit now in terms of the therapy? If somebody comes into the arthritis center, would you be able to give cyclosporin right now, or is it still in that clinical trial stage?
No, it's beyond the clinical trial stage. However, there are a number of other therapies that are more standard, in fact have less side effects than cyclosporin, and we take people through still the very traditional types of medications. And in fact, at the present time, the way we're dealing with the issue of cyclosporin in rheumatoid arthritis and in other disorders where it seems to be effective is that people are being carefully screened. They come into the arthritis center from all over the province. If it's felt that it's appropriate to give them cyclosporin, i.e. that there are no things that would get in the way of it. I mean, there are certain things that we feel, certainly at this point, would be contraindications to the use of cyclosporin. People, for example, who have severe kidney disease, people who already have high blood pressure. There are a number of things which would suggest that these people should not get it. But in fact, what happens is people come in, they're screened, and if they're found to be appropriate in terms of their disease and what they've already had for cyclosporin, it can be provided to them.
Right. There seems to be any questions, other questions? Yes, please, stand up so we can see you.
Okay. Some people who had polio when young are now later on in life having a return of it. Is there any hope for them in this treatment?
That's a whole different kettle of fish, so to speak. I think that at the present time we really don't understand very well what's going on in that particular condition, the post-polio syndrome. Whether or not it really is immune, we don't really know. And at this point in time, there's nothing to suggest that cyclosporin would be useful. And unfortunately, it's also a situation where we don't really know very well what would be useful to treat it at this point.
I guess that question opens up this whole idea that there are a lot of things happening at the same time. We're just beginning to understand what an autoimmune disease is, and you very eloquently told us there's got to be something in the environment, something, perhaps a virus, a bacteria, that turns something on in the body. The body then turns against itself, and perhaps that's what happens. We think that's what happens. Diabetes happens in arthritis. It could happen in other diseases as well. So at the same time as we're learning about this autoimmune idea, we're coming up with possible treatments for this, and then we have to find the right medications. So far what we have is cyclosporin. When you look down the road, you think it's going to end there?
Paul?
No, I think this is just the beginning, very clearly. We have brothers and sisters of cyclosporin which are now being tested, and we have completely different forms of drugs which are also being produced. I think the next 10 years are going to be very exciting. The world is moving very, very quickly now.
Right, so we're going to have more scientists running around with plastic bags looking for other...
All over, that's right.
Right. Sir, you have a question. Could you stand up, please?
Yeah, I have two questions. So why does gold treatment lose its effectiveness after a while? And is this likely to happen with cyclosporin? Will it lose its effectiveness in time?
Those are super questions. The first is that we don't know why gold loses its effectiveness. We don't really know why all of the treatments so far given for rheumatoid arthritis lose their effectiveness. And so far, we really haven't been following patients with cyclosporin for long enough to know what the long-term outcome is there. So we really don't know. Rheumatoid arthritis seems to be a disease which somehow can overwhelm the drugs that are being given for it. And as I say, at this point in time, we just don't know. That's one of the critical reasons to follow people who are on cyclosporin for rheumatoid arthritis very, very carefully and observe them and discover what the answer really is. Because, I mean, obviously, if this drug is going to maintain people ad infinitum, it has distinct advantages over other things. But that's something we don't know yet.
Something I've always been really curious about, though, and it goes back to the question, and that is that we know that gold now seems to have an effect on the immune system, perhaps not in the same way as cyclosporin. How was it discovered that gold could be used in arthritis?
Oh, that was, again, it was a sort of serendipitous. Gold was actually used for tuberculosis many, many years ago. It never worked, but it was used. And people looking at the pathology, at the joints in patients with rheumatoid arthritis, felt that the type of pattern of the pathology was very similar to tuberculosis. And so they said, well, why not try gold? And they did. And in fact, for many years, gold lost favor because of the significant side effects. But we've subsequently learned how to use it to minimize those. And it's one of our most successful treatments.
That's really interesting. We have a question in the front row.
I was wondering how cyclosporin is produced. Is it still derived from the fungi, or is it, have they found a way of synthetically mass-producing it yet? And if they do mass-produce it, will it become a lot more available to people who might not be able to afford it right now?
I'll take that if you like. The answer is yes, it's still produced in the same old way. It's brewed in huge vats in an old converted brewery in Switzerland. And yes, it is possible to produce it synthetically, but because it has so many amino acids, so many components in its structure, it would be more expensive to produce it that way rather than to produce it in its current way. So, no, we don't anticipate that it's going to get very much cheaper in the near future, but other new agents which come along, which are like cyclosporin in many ways, may be more effective and a little bit cheaper on the same basis.
I wonder if people in this room know that probably about 50% of all the drugs we use in British Columbia and across Canada were actually either derived from plants or microorganisms or still are. So, you know, we think about chemicals as being something that we produce on workbenches in labs, hopefully clean workbenches, but that's not always the case. We still go back to the sources when necessary, and this is a very good example of that. You have a question?
Yes, well, relative to you were talking about the treatment and the dosage versus transplantation and rheumatoid arthritis. I was wondering about the dosage. You mentioned that the patient had to be on it and had to stay on it. Does that dosage taper off? Do they build a tolerance to it, or can you taper off the dosage? Does the DNA get in a habit of doing this on its own?
Well, I think there's a different answer for transplantation and there's as compared to arthritis. In arthritis, we actually find that there's a very narrow range of dosage which we have to maintain in order to have the drug be effective. If we go below that level, what seems to happen is that the disease flares. If we go above that level, very often people get into trouble with side effects. So one of the things that we have to do when we have people on cyclosporin for rheumatoid is to follow them extremely carefully. The issue with transplantation is quite different, though.
That's right. We're very fortunate because we can reduce the dose by about 70% over the first year following transplantation. The body becomes attuned to the transplant that we put in. It's like getting married, if you like. In time, you learn to live with your partner. Well, in time, you learn to live with your graft also. Not completely, and so you need some cyclosporin.
Okay.
Good. Thank you for the question. Other questions? Yes. Please stand up.
Do you need to come up?
No, it's okay.
There's been a tremendous amount of research in the last 2-3 years into micronutrition, and I don't know if either of you gentlemen can address this area that is having a tremendous effect on things like lupus, psoriasis, and particularly rheumatoid arthritis, that may be making it possible for people to halt the disease before it takes hold to the point of those extreme cases.
Perhaps you could back up, Andy, and tell us again what lupus is.
Well, lupus is, again, a disease. It seems to have a stronger hereditary base than rheumatoid arthritis. It also affects women more than it affects men, and it also affects young women. And it's, in some ways, a more serious disease because it doesn't cripple, but it can kill. Fortunately, most people with the disease don't have that level of disease, so they don't have disease that's going to kill them off. But a proportion, about 30% of people, it can affect the kidneys, it can affect the brain, it can cause strokes, it can cause kidney failure. In fact, it's one of the reasons that people get transplanted is because they develop lupus and it involves their kidneys. So it's a really very serious disease. To answer your question, with respect to micronutrition, I'm aware that there's a lot of information that's publicly being promulgated about it. There's very little scientific work that's been done on the effects of micronutrition at this point in time, and there's very little scientific evidence that shows that it can turn off rheumatoid arthritis, for example. There's no question that certain manipulations of the diet can modulate, sort of make it a little better, make it less severe, reduce the number of flares, but not turn it off completely. So far, nobody's found a nutritional kind of mix that will do that. Unfortunately, I wish they had.
Right. Question?
Hi, this is for Dr. Keown. You mentioned that the level of cyclosporin can cause, if it is high, damage to the transplant. I was wondering if there's any damage to other organs of the body.
The main damage, you're quite right, occurs to the kidney if the level of cyclosporin gets too high. But there are other complications of cyclosporin which can extend to the liver, to the blood vessels, to the brain even. But those are very rare and usually only in the case of extremely high uncontrolled levels of cyclosporin. And what we all do now, whether it be an autoimmune disease or transplantation, is to measure the levels very carefully each time the patient comes to the clinic. If it's too high, we adjust the dose down. If it's too low, we adjust the dose upwards to get it into the right range. So many of the complications that we saw 10 years ago when we first started using cyclosporin, we never ever see now.
Which, just to follow up that, thank you very much. Just to follow up, when we hear about the possible side effects in the kidneys, is it mostly in the kidney that's transplanted, or is it in the one that remains that you have most of the problems with?
It can be in both. The kidneys seem to be sensitive to cyclosporin, whether they are transplanted kidneys or native kidneys. Now, people have argued that one may be more sensitive than the other. In autoimmune disease, for example, you would have native kidneys in place. In transplantation, your native kidneys are destroyed, so they're no longer susceptible to injury.
Right. In fact, this is the concern that we have in our rheumatoid arthritis patients, is that we have to keep an eye on kidney function constantly. And in fact, rheumatoid arthritis patients seem more sensitive to cyclosporin than people with transplantation, which may be, in fact, a factor related to the other drugs that they're on.
Interesting. Yes?
One thing I noticed that hasn't been addressed yet is what is the success rate of cyclosporin versus other drugs that may have been used in the past for transplantation?
Before we had cyclosporin, we had two major drugs that we used. Prednisone, which is a form of cortisone, and Imuran, which is a false component which is built into the normal sequence of DNA. Those gave us a success rate of kidney transplantation of somewhere around 50% with a lot of infection, a lot of complications. Now with cyclosporin we're looking at successes of between 80 and 90% with, as I think I mentioned, a very quick discharge from hospital, very far fewer complications. So it was like night and day when we could actually use cyclosporin for transplantation. It was an enormous improvement.
And what has the success rate been with cyclosporin in, say, rheumatoid arthritis so far?
Well, in the study that we just completed, comparing it with the other agents that we have, and remember that we treated very severely ill patients, so people who'd already done a lot of damage to their joints and who'd failed on everything else, we found that it was as effective as gold given to people with early rheumatoid arthritis, so extremely effective. There are very few other drugs that we have in our armamentarium for rheumatoid arthritis that are as effective.
So it bodes well for the future.
Bodes very well for the future.
But it does beg another question, and that is that if it is so successful, is there a way of predicting perhaps to use it almost before the fact, when the generation is not that difficult to deal with?
That's in fact what's being looked at right now. That whole area is still in the area of experimentation and in the area of study. There are studies being done in Canada, the US, Britain, and in Europe right now which are trying to address that issue, and hopefully we'll have some information. If in fact it looks that it's more effective and one should use it earlier, it may well be that our pattern of practice will change.
I think that there has been, actually, you mentioned Canada being so important in a number of areas in terms of investigation, rheumatoid arthritis. The other area, I guess, is in terms of autoimmune disease, is diabetes. And there were a lot of studies done at McMaster and in Ontario. And there they were using young children who I think were 2 or 3 years old, giving them cyclosporin to try to eliminate some of the early signs of diabetes. So Dr. Keown, this is what I mean. You have a situation where you have a child with diabetes. Is it too early yet to consider that as a treatment, or where are we going on that?
Yes, it's too early to consider it as a treatment. But there's no question that cyclosporin has been the tool that's allowed us to see that diabetes is a disease which falls into this class of autoimmune disease. 10 years ago, we largely thought that diabetes was due to a virus infection which destroyed the islets, which produced the insulin, and then the virus disappeared but left you diabetic. We know that's not true now, and we know it largely because of the studies with cyclosporin, which show that the body turns on its own islet cells and over a period of several years destroys them so that we become diabetic. Now, cyclosporin can prevent that, but only at doses which are very high, and so it's not a treatment for it yet. But I think what it does say is that the new drugs which are now coming along will almost certainly within the next decade or two be used to treat diabetes. And I think between the various treatments we now have, we will see diabetes disappear as a serious killer in our lifetimes.
That's amazing. I mean, we have people in this room, not necessarily me, who can remember when we couldn't treat arthritis, people sat in their beds and waited to die. That was perhaps 50 years ago, if not, maybe 40 years ago, 30 years ago. We now have some good physiotherapy treatments. We have other drugs. We have possibly cyclosporin in the future. You're telling us that probably the second or third common cause of major disease in the country might be eliminated very soon because of cyclosporin or other drugs. It's amazing. Now, there are some people who haven't asked any questions yet. Here's one. Could you get up, perhaps come over here? A little bit of exercise.
Okay. Dr. Keown, you were mentioning about the islet cells. I am wondering how soon that will be, and when it does come about, will cyclosporin be needed, or is the membrane that's being discovered now, will that preclude having to use cyclosporin?
In answer to your first question, the islet cell program in British Columbia will be starting very soon, and a few islet cell programs are already in existence throughout the world. Once we transplant the islets, we will either transplant them with cyclosporin or else coated in their little special polymer coat to protect them, because if you have the coat, you don't need cyclosporin. And I suspect in the longer term that the coated islet cells will prove to be the answer for us, but we haven't beaten all the chemistry of the coat yet.
Okay.
That's right. The body does it better than we do so far. There's another question back here.
I know that you were saying that cyclosporin is found in the soil, but what are the plants that contribute to the specific nutrients? Like, most plants have a chemical basis, and this is where a number of the medicines are derived. I'd be just interested in knowing which plants are responsible for those important nutrients.
For you?
No. I guess you guys are going to want me to take that one.
That's a tough one. Well, the fungus which produces cyclosporin is now known to be a very special kind of fungus. It was, first of all, misclassified in a very large class of fungi. And once cyclosporin became important, the botanists began to relook at this and gave it almost its own classification. In fact, we had a visit 10 years ago when we first began to use it in Canada by a team from the Royal Society who wanted to explore this question. They reclassified it and now it exists alone. But we're beginning to see now that fungi which we've all seen in the woods as we go walking every Sunday now suddenly produce substances which we realize are important. They of course produced them all along, but we didn't know they were important. Now we're beginning to take them, to distill them, to test them, and we can see that they have effects very similar to cyclosporin, sometimes even much more exciting.
Great. I think we have a question over here. Could you stand up, please?
You mentioned that one of the side effects was hair growth. I'm wondering, is that because the cyclosporin works in concert with hormones in the body, or is it unrelated?
I don't actually know.
Well, the one thing I think we do know is that it doesn't work in concert with any of the specific hair growth hormones that we know about at the present time. When we first started using cyclosporin, of course, we all used doses which are very, very much higher than now, and so the hair growth was a common problem. And we set in place a series of studies to look at this interaction with hormones and cyclosporin. We could find absolutely nothing that would give us a clue. And as we've all been able, I think, in autoimmunity and in transplantation, to reduce the dose over the last few years, this has become very much less of a problem. So the research in it has kind of dwindled. But the big thinking around that time was beginning to be that maybe cyclosporin works directly at the root of the hair follicle and triggers the growth at that point. It's very interesting because there are strains of animal, you've probably seen hairless cats, hairless dogs. There are strains of hairless mice which are completely nude, which grow not a single blade of hair. And with cyclosporin, these mice grow profuse furry coats.
When is the next clinical trial? What did you say?
I wonder if you gentlemen are considering it for yourselves.
We are indeed. We have our names down.
I think I'll beat you all there. But it does raise a question, and that is, again, a lot of the people that would have arthritis or diabetes or would have had a kidney transplant are taking other drugs. They're not just going to be taking cyclosporin. So what is known about the interactions between the drugs that they might be taking and the cyclosporin?
Well, there are a number of drugs that people shouldn't be on when they're taking cyclosporin. Drugs that either prevent the loss of cyclosporin through the kidney, such as some of the the diuretics, the drugs that, make the kidneys lose salt and water. There are a number of antibiotics that can potentiate the effects of cyclosporin. In fact, one of the things we do with our arthritic patients, and I know that is done with the transplant patients, is that our arthritic patients all carry a little card which says, I am on cyclosporin. The following drugs may not be used with cyclosporin, and they carry that in their wallet. And in fact, we insist that if ever they're put on a new drug by a doctor, before they take it, that they get in touch with us and that we discuss it with them. So they're a fairly large number.
What about simple drugs like aspirin, ASA?
Oh, that's one of the major problems. In fact, in patients with rheumatoid arthritis, in the trial, one of the things, everyone was on aspirin or an anti-inflammatory drug. And there appears to be kind of a double whammy from the cyclosporin plus the anti-inflammatories on the kidney. In fact, in the patients that we're treating now with cyclosporin, one of the first things we do is to get them off the anti-inflammatory drugs or reduce them to the very lowest level and try to maintain them on the cyclosporin alone.
Thank you.
What about alcohol?
Could you stand up and ask that, Willie?
What about the effect of alcohol or its effect on alcohol consumption?
Not as far as I know, no problem.
Not that you condone that, right?
No, but no problem.
No problem at all. Other questions? There probably are people in this room, I presume, because of the use of cyclosporin over the years, that know people who are on cyclosporin. Are there any true life adventures, or have you heard that people have really benefited from this compound? Yes, we have a number here. Yes, please stand up.
Me?
Yes.
Well, I was a diabetic, and my kidneys failed, and I had a kidney transplant about 2.5 years ago. And I'm doing really well now, thanks to the cyclosporin and the transplant.
Right, a living example. Yes. You're doing better than I am. Sir, you had a question.
Yes, well, I'm also an example of someone who had a kidney transplant about 4 years ago, and I'm doing very well. And I must say I'd like to take this opportunity to express the gratitude, which I'm sure that all the hundreds of BC residents who have also received kidney transplants, and the many thousands in Canada who have been, blessed by this great gift of life. Thank you very much.
Well, thank you very much, sir. I remember reading not so long ago, about 30 years ago, that in England there was a very difficult situation where there were too many people waiting for dialysis machines. And there was a discussion at that time as to what was going to happen when more people needed the machines. It seemed obvious that the science had to go to transplantation. The major problem was, as Dr. Keown has said, the problem was it a better treatment? Now it seems to be a better treatment, Dr. Keown.
No question. In every way you want to measure it, in terms of quality of life, of success, of duration of life, of cost, there's no comparison. In fact, I think my own personal vision of the future is, just as we've talked about diabetes disappearing, so chronic renal failure and chronic dialysis as we know it will disappear from the healthcare treatment over the next few decades.
Right.
As if, in fact, in British Columbia today, we had access to the number of organs we need, and we don't need very many more, nobody would have to go on dialysis. People would be able to go straight to transplantation and be relieved of their kidney failure.
At the moment, just now, how many people are waiting to have transplantation?
We have 200 on the waiting list. There are about 620 people on dialysis in the province. We have almost 1,000 transplanted patients that we're following in the province at the moment.
Right. We have time for one or two more questions. If there's anybody or somebody wants to make a comment. Yes, there's one here. Please stand up.
I was interested in the relationship between cyclosporin and psoriasis. Is this still experimental, or in what way is it being used?
At the moment, it's being used in a very similar way to the way we're using it in rheumatoid arthritis as an oral drug. What Dr. Keown referred to, which is something that will hopefully be available in the future, is to have it in the form of something that you can put on the skin, just as we're also hoping that we can deal with the eye problems that respond to cyclosporin with drops of cyclosporin for the eye. It isn't at the moment being pursued for release for use in people with resistant psoriasis. I know that there's a brief before the federal government right at the moment for that.
It must be a terrible problem. So many skin conditions still untreatable, and we're still looking for ways. Maybe cyclosporin might be the answer as well. Thank you. Another question.
This lady in the front row had a kidney transplant for diabetes, I understand, or diabetic complications. But I was wondering, with what you said about a pancreas transplant, is it the lack of organs that keeps that from being a basic treatment for diabetes, or is it just complications or the difficulty in the operation?
It's been both. Until very recently, it was just technically very difficult to do a pancreas transplant, and also to, even once the pancreas transplant was safely performed, to make sure it didn't reject, even with cyclosporin. But now we've been using cyclosporin with other medications in combination, and it's becoming much more effective. We're beginning to see real success now.
Thank you very much. Well, that's where we are, and it looks like the future is really bright. And I want to thank Dr. Andy Chalmers for coming today to talk to us about the possibilities of using cyclosporin in the treatment of arthritis and other diseases, and also for his excellent work here in the city in the Arthritis Center. And Dr. Paul Keown as well, who is the Executive Director of BC Transplant Society, and very interested in not just the use and clinical use of cyclosporin, but also the research aspects of how it can be used and how it might be used in the future. I think it was a very good way to begin, because cyclosporin, as I said before, really was the greatest discovery probably of the 1980s. Now we're looking forward to new and better cyclosporins, new and better possible uses of the drugs. So thank you very much, gentlemen, for coming, and thank you, the audience, for asking such incredibly good questions. Thank you very much. And now I'm going to choose one or two people at random and ask questions. So did you think you learned anything today?
Yes, I certainly did. I'd like to know more about the herbal background of cyclosporin, but it was informative.
Thank you very much. What about anybody else?
Well, I certainly learned a lot as well, and I'm sure that the success of the program will no doubt depend upon continuing research and a continuing focus on the many aspects of the disease and the ways in which we can relieve what is otherwise a very crippling condition for individuals. I think Dr. Keown has, of course, focused on one of the key points of the whole transplantation program earlier in the program, when he emphasized the importance of bringing to the public attention the need to be a donor if one was ever in the situation of having the unfortunate moment of not being able to continue, but was able to give one's organs in any respect to someone else. I think that is one of the greatest gifts that one can perhaps establish.
Well said. I think a really good way to end. Thank you very much, gentlemen.